Hello everyone. Today we will be discussing drugs affecting the autonomic nervous system. The resting activity of most organs is maintained by the opposing influences from the branches of the autonomic nervous system. The parasympathetic nervous system and its neurotransmitter, acetylcholine, and the sympathetic nervous system and its neurotransmitters, epinephrine, norepinephrine, and dopamine. It is important to evaluate the risk for adverse drug effects when using these or any drugs. The drugs may have a therapeutic effect on the target organ and an adverse effect on ancillary organs. For example, damage to the renal system or liver as medications are cleared from the body. Drugs that affect the autonomic nervous system are used for a wide variety of conditions and in settings from intensive care to primary care. Autonomic nervous system. Cholinergic includes constricted pupils, increased saliva, bronchoconstriction, increased gastrointestinal mucus, bladder fundus contraction. Adrenergic includes dry mouth, dilated pupils, increased contractility, increased heart rate, bronchodilation, and bladder fundus relaxation, sphincter contraction. Classification of autonomic nervous system drugs. Cholinergic drugs that include parasympathomimetic. Cholinergic blocking drugs that include parasympatholytic, anticholinergic, or antimuscarinic. Adrenergic drugs that include sympathomimetic, and adrenergic blocking drugs that include sympatholytic. Drugs affecting the sympathetic, also known as adrenergic nervous system. The first being alpha-adrenergic physiological activities include vasoconstriction of arterioles, resulting in higher blood pressure, pupil dilation, and relaxation of the gut. The second being beta-adrenergic physiological activities that include cardiac acceleration and increased contractility, vasodilation of arterioles supplying skeletal muscles, bronchial relaxation, and uterine relaxation. Drugs affecting the sympathetic, also known as adrenergic nervous system. Primary use depends on receptors activated. For alpha-1 receptors, they include nasal congestion, hypotension, and dilation of pupils for eye examination. For alpha-2 receptors, it includes hypertension. For beta-1 receptors, it includes cardiac arrest, heart failure, and shock. And beta-2 receptors, which include asthma and premature labor contractions. Activation of central alpha-2 receptors results in inhibition of cardio acceleration and vasoconstriction centers in the brain. This action causes a decrease in peripheral outflow of norepinephrine, leading to decreases in peripheral resistance, renovascular resistance, heart rate, and blood pressure. Because they lower blood pressure by reducing sympathetic function, they can produce compensatory effects on blood pressure, resulting in retention of sodium and expansion of blood volume through mechanisms that are not dependent on adrenergic nerves. Centrally acting alpha-2 agonists are used largely as second or third line drugs in the treatment of mild to moderate hypertension. Collodine has several off-label uses, including treatment of symptoms from opioids or alcohol withdrawal because of its ability to lower the associated adrenergic stimulation. It is also important to note that according to the Beers criteria, drugs in this classification may be inappropriate for use in geriatric patients. The drugs in this class, commonly used to treat hypertension, are collidine, guanabens, guanfacine, and methyl-dopa. Collidine and other drugs in this class activate alpha-2 receptors in the medulla of the brain, reducing sympathetic tone and increasing parasympathetic tone due to downregulation of alpha-2 receptors after chronic use. These medications should not be stopped abruptly because the relative lack of alpha-2 receptors impairs the homeostatic balance that regulates sympathetic nervous system action. The prescriber should gradually taper the dose when discontinuing the medication over 4 days. Some of the common adverse reactions related to oral and transdermal doses of these medications include bradycardia, AV block, palpitations, tachycardia, hallucinations, sleep disorders, contact dermatitis, dry mouth, orthostatic hypotension, constipation, nausea, urinary retention, decreased sexual activity, weight gain, leg cramps, and thrombocytopenia, with dry mouth being the most common adverse reaction. Cautious use is recommended in the presence of severe coronary insufficiency, recent myocardial infarction, and renal function impairment. Because they cross the blood-brain barrier, methyl-dopa and collidine are used cautiously in the presence of cerebrovascular disease. Collidine should be used with caution in patients who are at risk for mental depression, and it should be discontinued if depression occurs. Collidine should be avoided in patients at risk or with a history of bradycardia. Because they affect cognitive function, centrally acting alpha-2 agonist should be avoided or used with extreme caution in populations such as older adults for whom this adverse response creates a significant problem. All centrally acting alpha-2 agonists have additive sedative effects with central nervous system depressants and additive hypotensive effects with other drugs that also reduce blood pressure. Centrally acting alpha-2 agonists are used to treat mild to moderate hypertension and are second-line drugs usually chosen when other drugs are not effective in achieving blood pressure control. The exception is methyl-dopa, which is first-line therapy for pregnant patients. These drugs are not well suited for monotherapy because they produce troublesome adverse reactions in almost all patients who take them. Collidine is now approved by the U.S. Food and Drug Administration as an oral extended-release tablet for the treatment of ADHD in children as monotherapy or as adjunctive therapy to stimulant medication. Collidine has been evaluated for many off-label uses. It lowers the adrenergic stimulation associated with alcohol, heroin, and nicotine withdrawal and lessens the associated unpleasant symptoms. Rational drug selection. Age. Only collidine and methyl-dopa have pediatric doses and are approved for use in children. Collidine works better in adults but should be used with caution in older patients. Dosage reductions may be required for methyl-dopa and collidine when prescribed for older adults because of the risk for fluid retention and orthostatic hypotension. Pregnancy. Traditionally, methyl-dopa was the drug of choice for pregnant women due to the longevity of experience by providers. Patients who have difficulty taking pills, who have trouble remembering more frequent doses, or who for another reason would have better adherence to the treatment regimen with a transdermal system can be given collidine, the only antihypertensive currently available in a transdermal formulation. Because the transdermal form of the medication results in lower serum levels, lack of a peak associated with oral administration, this dosage form may minimize many of the drug's bothersome adverse effects. Monitoring. Clinical monitoring of blood pressure is appropriate for all drugs in this class, as with any other antihypertensive drug. Baseline blood pressure should be taken before initiating therapy and with each change in dosage. Weight and other indicators of fluid status should also be monitored. For patients who have or are at risk for renal impairment, dosage alterations are required. Assess serum creatinine before initiation of therapy and regularly thereafter for up to 1 year. Liver function studies should also be conducted before therapy and at 6 and 12 months. Methyl-dopa has been associated with hepatotoxicity. Patient education. Administration. The drug should be taken exactly as prescribed, at the same time each day, even if the patient is feeling well. Missed doses are taken as soon as they are remembered unless it is almost time for the next dose. Doses are not doubled. These drugs must be withdrawn slowly over 2 to 3 days to prevent rebound hypertension, and missed doses increase the risk for the occurrence of rebound hypertension. Methyl-dopa has known interactions with several herbals. Therefore, prescribers should ask the patients about herbal use and be aware that the drug interactions may occur. Drug-herbal interactions are listed in Table 11-3. Instruct patients who are on the transdermal collidine system about proper application of the patch. Apply the patch to a hairless area of intact skin on the upper arm or torso once every 7 days. Adverse reactions. Hypotension is the most common adverse reaction. Changing position slowly, not exercising in hot weather, avoiding alcohol, and drinking an adequate amount of non-caffeinated fluid per day will decrease these reactions. For patients with heart failure, fluid intake should be discussed with the healthcare provider. Drowsiness and dry mouth are also common. Patients should avoid activities requiring mental alertness until their individual responses to the drug is known. Dry mouth can be minimized by practicing good oral hygiene, chewing sugarless gum, or sucking on hard candy. Fluid retention is indicated by weight gain and swelling in the feet and ankles. Patients should report any weight gain of more than 2 pounds or 1 kilogram in 1 day to the healthcare provider. Hello everyone. Today we will be continuing our discussion about the topic of drugs affecting the autonomic nervous system. Adrenergic antagonist. Adrenergic antagonists act directly by blocking adrenergic receptors or indirectly by decreasing norepinephrine release within sympathetic nervous system terminals. Most of the clinically useful actions of these drugs result from the blockade of alpha-1 receptors in blood vessels, beta-1 receptors in the heart, and alpha-1 receptors in the bladder, neck, and prostate gland. Adrenergic antagonists are categorized on the basis of receptors that are blocked and include drugs that block only one receptor and those that block more than one receptor. Alpha blockers. Action. Block alpha receptors leading to vasodilation. Used to treat hypertension, benign prostatic hyperplasia, Raynaud's disease, and migraine headaches. Adrenergic antagonist. Beta blockers. Action. Antagonize or block the effects of catecholamines. Can be selective to beta-1 receptors or non-selective to beta-1 receptors. Mainly used for hypertension and after myocardial infarction. The alpha-1 antagonists reversibly block the effects of catecholamines at the postsynaptic alpha-1 receptors in vascular smooth muscle and in the smooth muscle of the bladder, neck, and prostate. These drugs are useful in lowering blood pressure as well as relieving outflow obstruction secondary to benign prostatic hypertrophy, also known as BPH. 6 drugs in this class are used clinically: doxazosine, prazosin, terazosin, tamsulosin, alfuzosin, and silodosin. It should be noted that prazosin is not typically used to treat BPH due to the frequent dosing requirements and risk of cardiovascular side effects. Tamsulosin, alfuzosin, and silodosin have increased selectivity for the alpha-1 receptors in the prostate, and as a result, these drugs have little effect on blood pressure while relieving symptoms associated with BPH. Adverse drug reactions, also known as ADR. Each of these drugs carries a risk for significant first-dose orthostatic hypotension that may result in syncope that tends to occur within 30 to 90 minutes of drug administration. This adverse reaction is decreased with continued doses, but returns if therapy is interrupted for even a few doses. The first dose should be given in the clinic or taken at bedtime. The first dose reaction may be minimized by starting with a 1 mg dose and slowly increasing the dose at 2-week intervals. Fluid retention that results in peripheral edema occurs with several of these drugs. Close monitoring of weight changes may be needed, especially early in therapy. All 6 drugs have increased risk for postural hypotension when administered with acute alcohol ingestion, other antihypertensives, or nitrates. Clinical use and dosing. Hypertension. Alpha-1 adrenergic antagonist, except alfuzosin, tamsulosin, and silodosin, which are not approved to treat hypertension, are the drugs of choice for treating hypertension in older men with concomitant BPH. Their actions simultaneously improve both conditions. Benign prostatic hyperplasia. Tamsulosin, alfuzosin, and silodosin have all been approved for treatment of symptoms of BPH. The recommended dose of tamsulosin is 0.4 mg once daily, administered approximately 30 minutes after the same meal each day. If the patient fails to respond to this dose after 2 to 4 weeks, the dose is increased to 0.8 mg once daily. Ureteral stones. Doxazosine, tamsulosin, and terazosin have off-label use as adjunct treatment to promote uterine stone expulsion. Post-traumatic stress disorder. Due to the role that norepinephrine appears to play in the pathophysiology of post-traumatic stress disorder-related nightmares, alpha-1 adrenergic antagonists are being studied as pharmacological methods of treatment. Prazosin is currently recommended for off-label use in clinical guidelines published by the American Academy of Sleep Medicine as an adjunct therapy for PTSD-related nightmares. Rational drug selection. Doxazosine is less likely than the other 2 drugs to produce postural hypotension and fluid retention, and may be used as monotherapy. Convenient dosing and tolerability. Terazosin and doxazosine are both longer-acting alpha-1 receptor antagonists, but both need to be titrated to the target dose because of hypotension issues. Tamsulosin is also a longer-acting alpha-1 receptor antagonist, but it produces a response without dose titration. Tachycardia. Although all drugs in this class may exhibit reflex tachycardia due to their antihypertensive effects, prazosin is an exception to this. The antihypertensive effect is not usually accompanied by reflex tachycardia. Indications: doxazocin, prazosin, and terazosin are all approved to treat hypertension. Doxazocin, tamsulosin, alfuzosin, silodosin, and terazosin are approved by the FDA for treatment of BPH symptoms, although dosage data for this indication are only published for prazosin. Monitoring. Clinical monitoring of symptoms, according to guidelines for hypertension and for BPH, is the main monitoring parameter. Fluid retention is monitored by weekly weighing and patient education about signs and symptoms of fluid overload to report. Reduced white blood cell counts of 1% to 2.4% have been noted, although no patients have become symptomatic with these lower counts. Patients who are to begin on alpha-1 adrenergic antagonist therapy for BPH should first have digital rectal examinations, and the provider should consider obtaining prostate-specific antigen. Administration. The drug should be taken exactly as prescribed, at the same time each day, even if the patient is feeling well. The first dose at initiation of therapy, and the first dose each time the dosage is increased, should be taken at bedtime to minimize the first dose effect, potential hypotension, and syncope. Missed doses are taken as soon as they are remembered, unless it is almost time for the next dose. Doses are not doubled. NSAIDs decrease the antihypertensive effects of most drugs in this class. Over-the-counter medications that contain NSAIDs should be avoided. Adverse drug reactions. Hypotensive reactions are the most common. In addition to taking the first dose at bedtime, teach patients to rise slowly from a supine position and dangle their feet over the side of the bed before arising. Not exercising in hot weather and limiting alcohol intake can also decrease these reactions. Nasal congestion and/or rhinitis may occur, which should not be treated with over-the-counter antihistamines or other cold remedies without first consulting with the healthcare provider. If the drug is being given for hypertension, encourage the patient to adhere to additional interventions for a reduction of blood pressure, such as weight loss, low sodium diet, smoking cessation, regular exercise, and stress management. Beta-adrenergic antagonists are used in the treatment of cardiac disorders such as heart failure and asymptomatic left ventricular dysfunction and after an acute myocardial infarction. They are also useful in a variety of other disorders including essential tremor, migraine headache prophylaxis, and hyperthyroidism. They act by occupying beta receptor sites and competitively preventing occupancy of these sites by catecholamines and other beta agonists. A major difference among these drugs is their selectivity for beta-1 and beta-2 receptor sites, and this difference has important clinical implications. These drugs blockade beta-adrenergic receptors, and they are usually referred to in healthcare literature as beta blockers. All beta blockers are well absorbed when given orally and are widely distributed in body tissues. All cross the placenta and enter breast milk. Central nervous penetration varies based on lipid solubility, with minimal penetration for acebutolol, atenolol, nadolol, and pindolol, with moderate penetration for timolol and metoprolol, with propranolol having the highest central nervous system penetration. Beta blockers are contraindicated for patients with respiratory conditions that include a bronchospastic component. These drugs are also contradicted for patients with AV block because their actions to decrease heart rate and myocardial contractility result in increased reduction in cardiac output and worsened failure. Older adults often have limited cardiac and renal reserves. Beta blockers are used to treat conditions common to older adults, but care must be taken with dosing. Closer monitoring of cardiac and renal status is required. Beta blockers may precipitate or exacerbate type 2 diabetes. Because of their effects on carbohydrate metabolism and their ability to mask the common symptoms of hypoglycemia, beta blockers must be used cautiously in patients with diabetes. The use of beta blockers during pregnancy is controversial because there have been individual reports of early labor, bradycardia, and restricted fetal growth. Note, however, that neonates of mothers who received these latter drugs had reduced birth weight and decreased blood pressure and heart rate at birth. Propranolol and metoprolol are excreted in breast milk, and the manufacturer recommends using caution when administering to nursing mothers. Beta blockers were an early drug of choice in the treatment of hypertension in children. Propranolol was the subject of original studies in this population, but more selective drugs such as atenolol and metoprolol were found to be better tolerated. Extended-release metoprolol was evaluated in a population of 140 children with hypertension and found to be effective. Adverse drug reactions. Cardiovascular reactions. Bradycardia, congestive heart failure with concomitant pulmonary edema, and hypotension are the most common cardiovascular adverse reactions. Central nervous system and psychiatric reactions. Fatigue, weakness, and dizziness are associated with reduced oxygen transport to the brain, secondary to excessive hypotension. Anxiety, depression, drowsiness, insomnia, nightmares, and mental status changes are more common in those drugs that have higher central nervous system penetration and in older adults. Endocrine reactions. Alterations in carbohydrate metabolism. Gastrointestinal reactions. Dry mouth is uncommon but may occur. Changes in GI motility may result in anorexia, nausea, vomiting, flatulence, and constipation or diarrhea. Genitourinary reactions. One of the most likely reasons for non-adherence to a treatment regimen that includes beta blockers is the risk for impotence or decreased libido. Respiratory reactions. Bronchospasm and dyspnea. Other reactions. Less common adverse reactions include muscle and joint pain, pruritic rashes, and facial swelling. Clinical use and dosing. Regardless of the indication for which a beta blocker is given, there is no simple correlation between dose or plasma level and therapeutic effect. Angina. Atenolol, metoprolol, nadolol, and propranolol are indicated for long-term management of angina. Beta blockers lower blood pressure, reduce symptoms of angina, improve mortality, and reduce cardiac output, heart rate, and AV conduction. To reduce the risk for ADRs, doses are started low and increased slowly, usually at no shorter than weekly intervals, based on resolution of symptoms. Hypertension. When initial drug treatment is being considered, most patients will benefit from the use of a single drug. However, starting with two drugs of different classes should be considered for patients with stage 2 hypertension. Beta blockers are not recommended as first-line therapies unless the patient has ischemic heart disease or heart failure. Initial drug therapy for hypertension is with a thiazide diuretic, angiotensin converting enzyme inhibitor, also known as an ACE inhibitor, calcium channel blocker, or angiotensin II receptor blocker. The preferred drugs to use in combination with beta blockers are thiazide diuretic or a dihydropyridine calcium channel blocker. Post-myocardial infarction, MI prophylaxis. Use of beta blockers in post-MI prophylaxis has been shown to decrease mortality by 30% to 40%. They are most effective for patients who have had severe anterior MIs. The mechanism of action in MI prophylaxis appears to be related to limitation of infarct size, prevention of primary arrhythmic events, protection from subsequent ischemia, and prevention of recurrent coronary occlusion. Migraine headache prophylaxis. Propranolol in doses of 20 to 80 milligrams 3 or 4 times daily has proved effective in reducing the incidence of migraine headache in some patients. The mechanism of action is related to prevention of beta receptor-induced vasodilation and promotion of increased extracellular levels of serotonin. For propranolol, if a satisfactory response to the maximum dose is not obtained in 4 to 6 weeks, the drug should be gradually withdrawn because a longer trial is not associated with a better outcome. For all beta blockers, abrupt withdrawal can be life-threatening. It can result in severe angina, MI, ventricular arrhythmias, and death. To withdraw any of these drugs, taper the dose by 1/2 every 4 days. Patients at high risk for serious consequences to rapid withdrawal include those with angina, coronary artery disease, and migraines. Rational drug selection. Beta selectivity. In selecting the most appropriate beta blocker, first consideration is usually given to beta-1 selectivity, sometimes referred to as cardioselective. Atenolol, acebutolol, metoprolol, and timolol are non-selective drugs. The clinical significance of selectivity relates to the relative lack of action of beta-1 selective drugs on the beta-2 receptors. The best choice of drug based on pharmacokinetics would be one with a long enough half-life to permit once-daily dosing, consistent bioavailability, and limited interpatient variability in dosing, limited central nervous system penetration to reduce adverse reactions, and an excretion mechanism that does not require dosage adjustments so that extensive laboratory testing before initiation of therapy is not required. Atenolol, metoprolol, nadolol, and nebivolol have longer half-lives that permit once-daily dosing regimens, although metoprolol frequently has its best effects with twice-daily dosing. All other beta blockers have half-lives that require at least twice-daily dosing, with propranolol requiring 2 to 3 times daily dosing. Monitoring. Monitoring parameters for beta blockers are essentially those that monitor the disease process they are being used to treat. For example, number of anginal attacks, lowering of blood pressure. For the drugs requiring dosage adjustments based on renal function, serum creatinine and/or creatinine clearance testing should be done before initiation of therapy. For drugs with significant first-pass effects, it may be appropriate to assess liver function before beginning therapy. Patient education. Administration. The patient should take the drug exactly as prescribed, even if feeling well. Doses should not be skipped or doubled. If a dose of atenolol, metoprolol, or nadolol is missed, it can be taken up to 8 hours before the next dose is due. Pindolol, propranolol, and timolol may be taken up to 4 hours before the next dose. Abrupt withdrawal may precipitate life-threatening arrhythmias, hypertension, and myocardial ischemia. Food may enhance the bioavailability of propranolol and metoprolol. They should be taken consistently either with food or on an empty stomach. Propranolol can be crushed and mixed with food, including oral solutions and semi-solids. Patients should consult with the healthcare provider before taking any over-the-counter drugs, especially cold remedies. Several drugs common in these preparations have drug interactions that result in hypertension and excessive bradycardia. Adverse drug reactions. Hypotensive reactions and bradycardia are the most adverse reactions. Rising slowly from a supine position and dangling the feet over the side of the bed before standing will reduce postural hypotension. Avoiding exercise in hot weather and adequate hydration with non-caffeinated fluids will also reduce these problems. Cholinergic agonist, also known as parasympathomimetics or muscarinic agonist, promote or mimic the action of acetylcholine. These effects may be achieved either by direct agonist effect or indirectly by preventing the breakdown of acetylcholine by acetylcholinesterase. There are three categories of drugs in this class: muscarinic agonist, cholinesterase inhibitors, and ganglionic stimulants. Direct-acting cholinergic drugs. Prototype: bethanechol, prototype, pilocarpine. Indirect-acting cholinergic drugs. Cholinesterase inhibitors. Prototype, neostigmine bromide. Muscarinic agonists are used clinically to treat glaucoma and improve GI and urinary bladder tone. Acetylcholine lacks selectivity to target tissues and is so rapidly destroyed by cholinesterase that its half-life is too short for most clinical applications. Its use is restricted to dilation of the pupil for ophthalmic surgery. Methacholine is used only for diagnosis of bronchial airway hyperreactivity by specialists familiar with its use for this purpose. Carbachol and pilocarpine are used to treat glaucoma. Bethanechol increases the tone of the detrusor urinae muscle and produces contractions strong enough to initiate micturition and empty the bladder. It stimulates gastric motility as well as increasing gastric tone and often restoring rhythmic peristalsis. Doses that stimulate micturition and increase peristalsis do not usually stimulate ganglia or voluntary muscles. Bethanechol can be given orally or subcutaneously. Effects appear 30 to 90 minutes after oral administration and 5 to 15 minutes after subcutaneous administration. The effects peak in 60 minutes for the oral dose and 15 to 30 minutes for the subcutaneous dose. Bethanechol is contradicted in the presence of many diseases. It is contradicted in peptic ulcer disease because at the usual therapeutic doses, it can cause excessive secretion of gastric acid that could intensify gastric erosion and precipitate gastric bleeding and possible perforation. It is contradicted in patients with intestinal obstruction because of its ability to increase GI peristalsis. Bethanechol is also contradicted in patients with hyperthyroidism. When initially given bethanechol, patients with hyperthyroidism react similarly to other patients by experiencing hypotension and bradycardia. It is not known whether bethanechol can cause fetal harm when given to pregnant women or if it can affect reproductive capacity. It is pregnancy category C and should be used only when the benefits clearly outweigh the potential risk to the fetus. Whether bethanechol is excreted in breast milk is also unknown. Adverse reactions are rare after oral administration, but more common after subcutaneous administration. Clinical use and dosing. Urinary retention. Bethanechol is used in primary care for neurogenic atony of the urinary bladder with retention. Oral dosing begins at 10 to 50 milligrams, 3 or 4 times a day. To avoid nausea and vomiting, the patient should take the drug 1 hour before or 2 hours after a meal. The subcutaneous form is intended for subcutaneous use only and should never be given intramuscularly or IV because the resultant high drug levels can cause severe toxicity, evidenced by bloody diarrhea, bradycardia, profound hypotension, and cardiovascular collapse. This drug may cause abdominal discomfort, salivation, sweating, or flushing. Teach the patient to notify the healthcare provider if these occur. The dose may be reduced or the drug discontinued. Dizziness or lightheadedness may occur when the patient arises from a lying or sitting position. Bethanechol is contraindicated in patients with asthma and other diseases with a bronchospastic component. Cholinesterase inhibitors. This class of drugs prevents the degradation of acetylcholine by acetylcholine esterase, thereby enhancing the activity of acetylcholine at cholinergic receptors. These inhibitors act as indirect cholinergic agonists, can intensify acetylcholine activity at all cholinergic junctions, muscarinic, ganglionic, and nicotinic, and so have a wide range of responses and adverse reactions. Myasthenia gravis. Neostigmine and pyridostigmine are used to treat myasthenia gravis. In this disorder, an autoimmune process occurs in which the patient's immune system produces antibodies directed against nicotinic receptors on skeletal muscle, reducing the number of receptors by 70 to 90%, resulting in muscle weakness. These drugs do not cure the disorder, but manage its symptoms. Treatment is lifelong. Establishing an optimal dose for treatment can be a challenge because these drugs produce widespread effects, not just at selected target organs. A small initial dose is administered, followed by other small doses until an optimal dose is reached. Signs of improvement that indicate optimal dosage include improved ability to swallow and to raise the eyelids. Alzheimer's disease. This disease is associated with a significant deficiency in brain levels of choline acetyltransferase, the enzyme responsible for the synthesis of acetylcholine. Donepezil, galantamine, and rivastigmine are all used to treat Alzheimer's disease by preventing the degradation of acetylcholine by acetylcholine esterase. The recommended starting dose of donepezil is 5 mg daily at bedtime. Doses are increased at 4 to 6 week intervals to reduce adverse reactions. The maximum dose is 10 mg daily. Rational drug selection. Formulation. For neostigmine and pyridostigmine, formulation is a consideration. Difficulty swallowing is a common problem for patients with myasthenia gravis. Pyridostigmine is available in a syrup form that can be used by many patients with this problem without having to resort to an injectable form. For patients with Alzheimer's disease, rivastigmine has an oral solution dosing formulation that permits it to be taken directly from the syringe or mixed with juice or water for those who have difficulty swallowing tablets. Once mixed, the drug is stable for 4 or fewer hours. Monitoring. Donepezil requires routine monitoring of blood chemistries and hematology. Baseline liver function studies seem advisable for galantamine and rivastigmine, but they are not required. Assessment of renal function is advisable for galantamine and memantine. Dosage adjustments are based on renal function. Patient education. Administration. Administration education differs for the two groups of drugs. All of the drugs should be taken exactly as prescribed. Doses should not be skipped or doubled. For neostigmine and pyridostigmine, patients may need to set up a backup alarm to remind them to take a dose when the doses are every 3 to 4 hours. Taking the dose late may cause myasthenic crisis, and taking it early may result in cholinergic crisis. Because drug therapy is lifelong, it is important to establish a regimen with that the patient can follow over time. For donepezil, missed doses should be skipped and the schedule resumed the next day. Missed doses of galantamine, rivastigmine, and memantine should be skipped and the next dose taken as scheduled. Cholinergic blockers. Cholinergic blockers are also referred to as parasympatholytics, muscarinic antagonists, and anticholinergics. There are several subtypes of cholinergic blockers based on the organs they are likely to target. Atropine is the prototype drug in this class and affects most muscarinic receptors. Its main use orally is as an adjunct to treatment of GI disorders. Scopolamine has actions similar to atropine except for increased central nervous system depression and ability to suppress motion sickness and emesis. The antispasmodic group of drugs is indicated for reduction of GI motility and urinary tract smooth muscle spasm. Ipratropium bromide is used to treat acute exacerbations of asthma and other respiratory diseases such as COPD. Adverse drug reactions. Adverse reactions to cholinergic blockers are based on their actions on tissues other than the target tissue or organ. The discussion here focuses on the adverse reactions on each organ system. Cardiovascular. Cholinergic blockade eliminates the parasympathetic influence on the heart, resulting in tachycardia. Respiratory. Cholinergic blockers are sometimes used to produce relaxation of bronchial smooth muscle for patients with an acute exacerbation of asthma and with COPD, but their tendency to thicken and dry bronchial secretions can result in ineffective airway clearance and make patients at higher risk for respiratory infection. Exocrine glands. Blockade of muscarinic receptors on sweat glands can produce anhidrosis. Because sweating is necessary for cooling the body, patients are at risk for hyperthermia. The effect on salivary glands produces xerostoma. This can be irritating and can impair swallowing. Gastrointestinal and urinary. Decreased tone and motility in the GI tract can lead to constipation, especially when the secretory function of the intestine is also reduced. Blockade of muscarinic receptors in the urinary tract reduces contractile force and pressure in the urinary bladder and increases tone in the urinary sphincter. I. Mydriatic and cycloplegic action of cholinergic blockers results in increased intraocular pressure, blurred vision, and photophobia. Central nervous system. Cholinergic blockers that cross the blood-brain barrier produce varied adverse reactions, from mild excitation to dizziness and confusion, and in the case of scopolamine, central nervous system depression. Monitoring. No specific monitoring parameters are required for cholinergic blockers beyond monitoring for adverse reactions and the monitoring parameters that are appropriate for the disease being treated. Patient education. Administration. Instruct the patient to take the drugs exactly as prescribed. If a dose is missed, take it as soon as remembered, unless it is almost time for the next dose. Doses should not be doubled. Benztropine is administered with food or immediately after meals to minimize gastric irritation. The tablet may be crushed and administered with food if the patient has difficulty swallowing. Atropine, dicyclomine, and propanthyline are administered 30 to 60 minutes before a meal. Oxybutynin is administered on an empty stomach. May be given with food to minimize GI irritation. Adverse reactions. Cholinergic blockers have many adverse reactions because their actions are not organ-specific. Cardiovascular reactions include tachycardia. Teach patients to take their own pulse and report heart rate above 100 beats per minute. Dosage adjustments may be required. This adverse effect is especially problematic for patients who concurrently have coronary artery disease and for older adults. Cholinergic blockers tend to thicken and dry respiratory secretions. Advise patients to drink at least 2 quarts of non-caffeinated fluid daily to maintain adequate hydration. Fluid and fiber intake are also important because these drugs may cause constipation and difficulty voiding. Dry mouth can be relieved by practicing good oral hygiene, consuming cold drinks, sucking on hard candy, and chewing sugarless gum. The therapeutic goal for many of these drugs is to reduce gastric secretion. Substances that increase gastric acid secretion, such as alcohol, tobacco, caffeine, and aspirin, should be avoided. Activities that require visual acuity, mental alertness, and vigorous activities in warm weather can create problems. Cholinergic blockers may result in blurred vision, photophobia, and dizziness, and they reduce the sweating necessary to cool the body during exercise.